Good morning and welcome to today's webinar about heart monitoring and cryoablation treatment for atrial fibrillation. I'm Melanie Truhills, founder and CEO of StopAFib.org, a patient advocacy organization for those living with AFib. I'm honored to be your moderator for today's program. As you all know, September is AFib Awareness Month. Living with AFib can be really difficult, and the more we all know about AFib, the better we can partner with our physicians to make decisions regarding our care. Our goal for AFib Awareness Month is to bring attention to this life-altering condition and to help people living with AFib learn more about it. Thank you to Medtronic for hosting this important educational webinar for AFib Awareness Month. We have an exceptional speaker today, Dr. Ilyas Colombowala, an electrophysiologist from Houston Heart Rhythm in Houston, Texas. Before we begin, we want to cover a few housekeeping items. If you'd like to expand your video window so that it's full page, click the icon in the lower right of the video window, the one with 4 arrows that point outward. To revert back to the original size so you can submit a question, click on Escape at the top left of your keyboard. If you have any questions during the webcast, please submit them in the Q&A box on the right side of the video window. We'll answer as many questions as we can during the webcast, and if a fuller answer is needed or if we run out of time, that question will be answered later via email. And also, please know that we're recording today's webinar. On this slide, please take a moment to note Dr. Colombowala's disclosures. Medtronic would also like to share a few additional important bits of information as it pertains to this presentation. We also want to remind you that the results described in the presentation are unique to these patients. Not every patient responds the same. Results may vary. Please talk to your doctor about your condition and the risks and benefits of the Medtronic products and treatments described in this presentation. Now, please let me introduce to you Dr. Ilyas Colombowala, who will be today's speaker. He has over 20 years experience as an electrophysiologist. A native Houstonian, he attended Dartmouth College. He graduated from Baylor College of Medicine in 2002 and completed his internal medicine residency and cardiology fellowship while at Baylor. Dr. Colombowala practiced as an electrophysiologist for 2 years at Texas Heart Institute in Houston, Texas, before moving to Kalispell Regional Healthcare in Kalispell, Montana for 4 years. He returned to Houston for 2 years and then back west to Boise, Idaho, where he spent 5.5 years at St. Alphonsus Regional Medical Center as chairman of the Department of Cardiology and Cardiac Surgery. The Pula family once again brought him back to Houston as of a few weeks ago. Dr. Colombowala is now a practicing electrophysiologist at Houston Heart Rhythm. He approaches all patients as individuals, carefully managing risk factors and conditions leading to heart disease and arrhythmia. With that, let me turn the floor over to you, Dr. Colombowala.
Thank you, Melanie, so much. And I'm really honored as well to be able to speak to all of you about atrial fibrillation. Atrial fibrillation is really the most common cardiac rhythm disorder. And as a cardiac rhythm specialist, I really enjoy taking care of patients with AFib. And the reasons for that are many. Really, atrial fibrillation is the care of the whole patient, from managing risk factors to treating the actual rhythm condition. And then after we're able to successfully manage atrial fibrillation, we keep a long relationship with our patients as heart rhythm specialists because it's an ongoing thing. So today we're going to talk about what atrial fibrillation is, what risks are associated with atrial fibrillation, what it feels like to have atrial fibrillation, how you know, how the diagnosis is made, and then we'll get into some treatment options and long-term monitoring options. Because as I tell my patients, atrial fibrillation is a chronic disease. This isn't something that just happens once and then never happens again. This is really a cardiac rhythm condition that needs to be managed over a very long time. So let's start right into what atrial fibrillation is. To put it very simply, the heart has 4 chambers. It has 2 upper chambers and 2 lower chambers. Atrial fibrillation is a disease of the upper chambers of the heart. And what happens in atrial fibrillation is that the upper chambers begin to beat very rapidly, and they almost quiver. And in that quivering of the upper chambers, there's not effective blood flows. Typically, in a normal heartbeat, those upper chambers pump blood. Now, the upper chambers don't provide most of the pumping function of the heart, but they do provide some of it. And that feeling of atrial fibrillation where the upper chambers stop working properly can be very uncomfortable for people. It also significantly increases the risk of stroke. Atrial fibrillation patients are actually at a 5 times increased risk of stroke. And so that's one of the big things that we deal with in taking care of AFib patients is mitigating that risk, because strokes are debilitating and life-changing for many patients. Generally speaking, patients with AFib experience some symptoms that may be really obvious to the patient, but could be subtle, things like just decreased energy, a feeling of apprehension, and so on. Often people are limited in what they're able to do and in their quality of life. So how do you know if you have AFib? Well, some of the symptoms of AFib are, as I just described, irregular, rapid palpitations, fatigue, shortness of breath, and weakness. Some people experience chest pain or discomfort. Often we hear that people just feel a little dizzy or a little off. But really, AFib can be completely asymptomatic as well, and that's important to know. So how did I get AFib? What are the causes of atrial fibrillation? I usually tell my patients that really kind of one of the most common causes is just getting older. It's a disease of the body getting older, of the heart chambers getting older, but there are some things that predispose people to AFib. Heart abnormalities, damage to the heart from heart attacks, valve problems are a common cause of atrial fibrillation. Also, lifestyle things like drinking alcohol can increase the risk of atrial fibrillation. Obesity, smoking, high blood pressure, these are all risk factors for AFib. And those are some things that we can actually manage. And so in taking care of the AFib patient or the patient at risk for AFib, we really try to be aggressive about managing lifestyle things that are reversible that could help prevent the next episode of AFib. Atrial fibrillation is a chronic progressive disease. It starts out as something that we call paroxysmal, and that describes the type of AFib that comes and goes on its own. So AFib starts out typically as a cardiac rhythm problem that may happen for a few minutes or a few hours. And then generally speaking, for most patients, this, if left untreated and unchecked over time, progresses down a pathway to where one goes into AFib, gets stuck in AFib, and eventually, at some point, if the AFib isn't managed, often patients end up in what we call permanent atrial fibrillation. And that's a type of AFib, that's sort of the end of the road. That's the point at which the patient and the doctor decide together that there's really not anything that can be done to keep them out of AFib. So what are some treatment options? We want to try to attack AFib at the earlier stages, because when we do that, we have a lot higher likelihood of being able to reduce the burden, as we call it, of atrial fibrillation, reduce the number of episodes or the length, the duration of the episodes. We can do that with antiarrhythmic medications. We can do that converting the patient with an electric shock that we call cardioversion. Now that's done under sedation. We convert the rhythm back to normal, but we typically consider that a temporary fix. Pacemakers and defibrillators can help detect AFib, and in some patients help suppress the onset of atrial fibrillation. Catheter ablation is a procedure that we're going to spend a little bit of time talking about today. And that procedure, along with some patients require surgery, those procedures are a little bit more definitive in terms of helping manage atrial fibrillation. I do like to tell people, though, that nothing's perfect, and these are really good treatments for atrial fibrillation, but I like to consider them treatments for AFib rather than cures for AFib. And that really highlights the idea that even though one undergoes a procedure for their AFib, they're still always at risk. And so we still have to manage risk factors, and we want to keep taking care of that patient as though they're at ongoing risk of a recurrence of AFib. So let's talk about why we want to treat AFib. The big things are, number one, and I would change the order of the goals on this slide. The number one thing, we want to reduce a patient's risk of stroke, because as I said, and as you know, stroke is debilitating and life-changing, and really is an awful thing to have happen. And we want to reduce that risk as much as possible. Typically, we do that with blood thinners. And then apart from the stroke risk reduction, we really want to help patients feel better, live their best life, their best quality of life, to keep doing the things that they enjoy doing. And that's really our goal. And the more we can keep a patient in normal rhythm, the more we delay the progression of the AFib. So let's talk a little bit about catheter ablation for atrial fibrillation. Catheter ablation for AFib is a procedure where we typically will enter the vein in the leg and go up to the heart and treat the AFib. Now, how do we treat the AFib? Well, in 1998, a paper came out in the New England Journal that got everybody really excited about the potential for treating AFib. It was discovered that, generally speaking, in almost all cases, the triggers for atrial fibrillation originate in the veins that bring blood from the lungs back to the heart. And so the idea was that if you can somehow corral off those signals, keep them in the veins, those electrical signals, and keep them from entering into the heart chambers, you can prevent the atrium from fibrillating. And so over the last 20 plus years, the tools have developed to how do you get that tissue to not allow the electrical signals from those veins to enter into the heart. We've gone through so many iterations and so much advancement in this field, but we've basically come down to two main strategies to effectively destroy that tissue, keep the electrical signals from coming into the atrium. The initial approach involved radiofrequency ablation. That was our go-to for how to destroy the heart tissue in very small quantities, but enough to keep those signals isolated. And radiofrequency ablation, basically that's sort of a fancy word for delivering heat to the heart tissue. So it effectively cooks the heart muscle, and it keeps that muscle tissue from being able to transmit electricity. Eventually, the idea was that maybe we can cool and create a little bit of a frostbite injury to the tissue. And so it was developed the cryoballoon. And cryoballoon basically means a balloon that fills up with a very cold gas and is able to create enough disruption to that tissue that those electrical signals stay inside the vein. The cryoablation catheter was developed with Medtronic and has been used for over 16 years. We have a huge amount of experience now with the cryoballoon, and it's a highly effective way to keep that AFib from coming from the pulmonary veins and into the atrium. Medtronic has also developed a new radiofrequency catheter that is also very effective in providing those lesions that we use to help treat AFib. And this is called the diamond temp catheter. And this is a really sophisticated radiofrequency catheter, and it allows us to deliver treatment to very small areas as they're needed. So catheter ablation is an excellent option for patients with atrial fibrillation. And at this point, early on, it used to be sort of a, let's treat AFib for a while, see how it goes. And by that, I mean with medications. And if everything else fails, we go to an invasive procedure. We're really shifting these days in the management of atrial fibrillation to early aggressive treatment. And so for a lot of patients, the right approach is to go to catheter ablation early in their treatment. And as I was saying earlier, the better we treat AFib at the early stages, the better chance we have of preventing that atrial fibrillation from progressing to a more persistent or permanent status. And this slide effectively kind of reiterates that point. Again, the earlier you treat AFib, the more you can prevent complications from atrial fibrillation, and the better shot you have of preventing the progression. We can use cryoablation, and it's the first and only FDA-approved ablation device to use for first-line management of atrial fibrillation. And so I use quite a lot of cryoballoon in my practice. The reasons I use that strategy are many, but I find it to be a very safe and effective way of isolating off those pulmonary veins. Patients do quite well. The data supports using the cryoballoon as a strategy, especially in earlier stage AFib. We get really great results from this strategy. So how does it work? So basically, to describe the procedure to you, we start IV lines in the groin. We introduce these catheters, and you've seen pictures of those catheters in previous slides, up to the heart. And that balloon basically pushes up against the pulmonary vein, and that cold energy creates a little bit of a frostbite injury in that location. And it's a durable long-term lesion that keeps those signals in the pulmonary veins. And so once we find the targets for ablation, and generally speaking, we ablate all 4 pulmonary veins. We deliver that energy. The procedure is done typically over the course of takes about an hour to 2 or 3 hours. And a lot of times patients go home the same day. Sometimes patients spend the night. It just depends on the specific scenario and the physician and the hospital and the patient. But it's a procedure that's effectively entirely done through IVs that we start in the leg. And so this is not, in a catheter ablation procedure, we're not talking about open heart surgery. A lot of people would consider this a minimally invasive approach, or minimal impact to the patient, because again, it's all done through fairly large IVs, but IV lines. So what's sort of the pre and post for the procedure? Well, it's usually pretty easy. We often adjust some medications prior to the procedure. A lot of times we'll make sure that somebody's on a blood thinner prior to their procedure. Nothing to eat or drink for a few hours before the procedure. In some hospitals, patients are allowed to have clear liquids up until a couple of hours before the procedure. And then after the procedure, what to expect. As I said, sometimes patients go home the same day. Before you go home, there's going to be a period of bed rest in the hospital, because we've used some pretty large IV lines in the leg. We want to make sure that those don't bleed. So a few hours of bed rest, you go home. I generally tell people to expect to be sort of on light duty for at least a week or so. But generally speaking, one can get back to all of their usual household types of things. By the next day, it's pretty easy to walk around. There may be some soreness in the groin, but again, anything outside of mild soreness, etc., should be brought to the attention of your doctor, and because it might be the sign of something else going on. So again, what are the benefits? Well, like I said, the earlier you treat AFib, the better you can prevent the progression of atrial fibrillation. We can really help in terms of reducing the burden of atrial fibrillation, if not eliminating atrial fibrillation, so as to help patients feel better, have a better lifestyle, have more energy, be able to do the types of things they want to do, etc. And so this early treatment with catheter ablation is an excellent option for a lot of patients. Now let's get into heart monitoring for atrial fibrillation. Before and after catheter ablation, monitoring the heart rhythm, seeing what's going on with the heart rhythm is so important. As I said early on, atrial fibrillation is definitely not a spot check kind of disease. It's the type of condition where it is so helpful for us as clinicians to have a really good picture of what's going on with the heart rhythm, and a complete picture. We want to know if the heart racing that somebody comes in with, is that AFib in the first place, or is it something else? Once we start treatment, we want to know if, for example, if we put you on medication for your atrial fibrillation, is that medication even really doing anything? I mean, you might feel a little bit better, or you might not feel better. Either way, we might find that the amount of AFib that you feel has changed from before you started treatment. A medication may reduce the amount of AFib you have, even though you still feel it. And it may not be working at all, in which case it may not be helpful to continue that medication or treatment strategy. There's lots of different kinds of heart monitors, and they're all quite useful, and we use all the different types. Everything from consumer grade monitors, watches that people have that can monitor their ECG or can catalog their AFib events. The Holter monitor is a 24-hour monitor. We sometimes use longer term external monitors. But I think that the best way of monitoring atrial fibrillation is using a tiny little implantable monitor that can record the rhythm 24/7 for an extended period of time. Let's just kind of talk about some of these, the pros and cons of different strategies. Wrist-worn monitors are really helpful. In fact, a lot of patients, the first time they find out that they have AFib is from their watch, and they get an alert saying, you've got AFib, talk to your doctor. And that's quite helpful for a lot of patients. And some people just like to have the reassurance of a device that will tell them on the spot what they have. So another way to monitor heart rhythm is using spot reading technology. There are monitors that are available that you can put your fingers on. They'll sort of connect to your phone, and you'll get an ECG reading. And sometimes you can get you can sign up for a service where a physician looks at it and tells you if it's AFib or not. Some of it's automated, and other times it's not. But you can have a recording of your heart rhythm, and you can share it with your doctor and so on. But again, the big thing about the spot reading technology is that often people will only take a reading when they have symptoms. They may have AFib at other times that doesn't have any symptoms at all. A lot of times I'll tell people that AFib is kind of like an iceberg, and people say you see the tip of the iceberg at the very top. That's the stuff you feel, but then there's this huge amount of AFib that you might have under the surface of the water that you don't feel. And so the spot reading technology doesn't necessarily give you a really good idea of what the AFib burden is. Holter monitors are usually about 24, 72 hours. Event recorders are up to about a month. And again, all of those are ways to monitor rhythm externally. But the insertable cardiac monitor, initially really developed by Medtronic, has been a total game changer in the way we take care of AFib patients. We can get diagnosis earlier, we can treat AFib earlier, and then over the long term, it really helps to take care of the AFib patient. In fact, if you just use the sort of conventional monitoring strategies, like things that we talked about, the 24-hour check, the 48-hour check, or even up to a month, you can miss up to 85% of patients who have AFib that you pick up with long-term monitoring. I mean, so there are a huge number of patients. For the high-risk patients, a huge number of them have AFib. The ones where we, as physicians, think you got to have AFib. If you monitor long enough, you're going to find it a huge amount of the time. And so a lot of times we'll start with the sort of more basic monitoring strategies. But if we don't get the answer, or if we have, maybe we see some rhythms that are precursors to AFib, then I typically encourage patients to have an insertable monitor when I think that there's going to be a benefit to having that long-term data. Here's it's a graph that's a little confusing. I just kind of want to show you what AFib might look like to a monitor. And so if you look at this graph, you see a bunch of blue bars, and then you see kind of a smear of red. So those are, let's just call those are two different patients. But what you can see here is that the patient, it's labeled letter A, the blue bars, has a little bit of AFib or a lot of AFib every day, but not necessarily all day long. So on the y-axis of this graph, it's the time in AFib, and on the x-axis, it shows the different days. And so if that patient A went to the doctor, let's just say on day 1 and then again at day 90, so 3 months later, and they happen to be in AFib during those hours that they're at the doctor's office, it's going to look like just getting the EKG check in the office that patient's been in AFib continuously. But in fact, that patient is still what we call paroxysmal, where they're in and out of AFib every day for a little bit of time. But patient B might go to the doctor on day 0 and have no AFib, and then go back after they feel funny for a while. As you can see, that whole area in red is the time they're in AFib. But say they go to the doctor on day 120 and get an EKG check, and they say, gosh, I haven't felt right for the last, if you look at the graph, for the last 2 months, I haven't felt well. And they'll get an EKG in the doctor's office, and lo and behold, they're in normal rhythm that day. So you have somebody here where they've been in AFib for 2 months, and if you just spot check on 2 different days, you totally miss the diagnosis. And you don't understand why they've been feeling poorly for the last 2 months. So even after you're diagnosed with atrial fibrillation, even after we treat the AFib, the monitoring strategy really matters a lot. It helps us to make good decisions about how we treat AFib. It allows us to correlate symptoms and rhythm so that when somebody comes in and says, gosh, I didn't feel well last week, but I feel a little bit better now, we can go back and look at their long-term data and say, well, you had 3 days of AFib last week. And it helps us know if what we're doing is the right thing. Should we shift gears? Should we keep doing what we're doing? What have you. And beyond the diagnosis, even after we treat AFib, we really want to have long-term data, because often patients will do well for an extended period of time. But it could very well be that a couple of years later, just when they think, I'm in the clear, out of the woods, they have AFib again. And it's so important to know that, because a lot of times, whether it's medically advised or not, patients make changes to their lifestyle or to their medications. They decide to stop taking something. It's so important to know if there's been a recurrence. I often tell people that after an ablation procedure, for example, AFib feels different to many patients, whereas they might have been quite symptomatic before their procedure. Once they have the procedure, oftentimes patients don't feel the AFib anymore. And so they can have a false sense of security that everything's going great, I feel great, I don't need to worry about my AFib anymore. Maybe I'll just decide to stop my blood thinner. But in the background, they're having AFib and they're still at risk for stroke. And so we've kind of talked about this over and over, but again, just to emphasize the importance of knowing what's going on, to have that data, to use hard data and not necessarily just how one feels, although that is really important. And I encourage patients to write down on calendars or little diaries, if they feel something, write it down, pick a day, say, gosh, on August 30th, I felt terrible. The nice thing about having a monitor is we can go back to August 30th and say, was that AFib or did you just feel terrible because of something else? So there's two different implantable monitors that Medtronic makes. The original Reveal Link monitor, they still manufacture that one. It's the smallest insertable monitor. It lasts for 3 years. It does a fantastic job of determining AFib versus not AFib and cataloging that rhythm. Medtronic actually took a really great thing and tried to make it even better with the Link 2. They increased the battery longevity. The Link 2 monitor is ever so slightly larger, but it also works over Bluetooth with a patient's smartphone. And so they always have connection between their monitor and the doctor's office can pull that data and take a look at what's going on. There's slightly more sophisticated algorithms, although I would say that in both devices, they are so accurate and so good at finding AFib and cataloging those irregular heart rhythms and what have you. I have full trust in both of these monitors to do that for my patients. You can have an MRI with both of these monitors. In fact, right away, if you get one of these monitors put in and somebody the next day says, you need an MRI, you can have it. There's no waiting period and it's perfectly safe to do so. This is what the doctor sees, just so you can kind of get an idea of, when you have one of these monitors put in, what does the report look like to the doctor? Well, this is actually my favorite page of the report. We get quite a bit more information from the device, but as you can see, that top bar graph on the report is kind of the thing that I look at the most. So when I see somebody, I really want to know how much AFib are they having, and that bar graph, it's basically a calendar across the top. And then the y-axis is how much time were they in AFib on each day. And as you can see here, this patient has had a very tiny amount of AFib. Their AFib was just a few minutes on a couple of days. And other than that, they've been in normal rhythm. Some patients you see come in and it's just blue all the way across the top. And that tells you that they've had a lot of AFib. And that maybe if you're treating it, if you're treating the AFib, that what you're doing isn't really getting the job done and that you need to shift gears. Other information that's useful is how fast is the heart beating. A lot of times you'll see that in AFib, a patient's heart rate is a lot faster than when they're in normal rhythm. And then we can even see things like what the patient activity has been. And so a lot of times what you see is somebody will be quite active until they go into AFib. And then you'll see that graph, patient activity, it's about 1, 2, 3, 4, 5 things down. Patient activity will just go down right when they go into AFib. And so it really helps you kind of correlate rhythm and symptoms and how somebody feels and so on. So with that, we'll get to your questions. I always think that this is kind of the best part and more fun. Hopefully be able to answer your questions and whatever you have for me. I'm here to try to answer them. I'll do my best. And we usually get a lot more questions than we have time for, but know that we're going to keep all those questions and try to get them answered and get those answers out to you as well.
Thank you so much, Dr. Colombowala. We are getting a lot of questions coming in, and so let's start with some general AFib questions, then we'll move to ablation and monitoring. But one of the first questions is, and this is something that we in the AFib patient community talk about a lot, and patients want to know from their doctors, what do I need to do when I have AFib symptoms? And more importantly, do I need to go to the emergency room?
That's a great question. Generally, you don't need to go to the emergency room. Now, it sort of depends. If you know you have AFib and you're on a blood thinner, and perhaps you know that if I just rest for a few hours, it'll probably stop, that's probably all you need to do. Now, if you have symptoms of AFib, but nobody's ever made that diagnosis before, and we're kind of wondering, why do you have palpitations? we've never been able to capture it on an EKG, we've never made the diagnosis, you should seek medical attention urgently, because this is our opportunity to record what the rhythm is on an electrocardiogram and make that diagnosis that can be so helpful over the long term. In stroke risk reduction, that's the biggest thing. If we can make the diagnosis of atrial fibrillation, we, generally speaking, will start a blood thinner for many or most patients. And so we don't want to miss that opportunity to make the diagnosis.
Right.
Another reason you might want to seek more urgent medical attention is that your heart's just racing and you feel very uncomfortable, chest pain, shortness of breath, and so on. Sometimes the rhythm can be converted in the emergency room setting back to normal, and that sort of buys you some time to seek cardiology attention and get your AFib treated and managed. And so there are some reasons to get medical attention urgently, but for some patients, for many patients who have known atrial fibrillation, just not feeling quite your best and thinking you're in AFib doesn't necessarily mean you need to rush into the emergency room.
Okay, terrific. Thank you. Another frequent question is, how does family history affect your chances of developing AFib?
Well, sometimes I tell patients that come in that say, well, gosh, my mom and my dad had AFib, and my brother had AFib, and my grandma had AFib. The bad news is they picked the wrong parents. And so family history is a really big thing with AFib. It does tend to run in families. But for other patients, it's irrelevant. Their parents didn't have AFib, but they do. And so we can't always say that. And just because your parents had AFib doesn't necessarily mean that you're going to develop atrial fibrillation, but it is a risk factor.
Another question is, what can be done for long-term constant AFib?
That is a trickier thing to handle. It's a harder disease state to treat. There are treatment options out there. Long-standing persistent atrial fibrillation, just sort of by definition, is somebody that's been in AFib for more than a year. And a lot of times, those patients are good candidates for a surgical AFib treatment strategy. Catheter ablation can still be considered, and often is a treatment strategy for those patients. But as we get into for somebody that's been in AFib for an extended period of time, sometimes a better approach is to do a hybrid surgical and catheter ablation type approach. And some of those patients, really, to back up a step, some patients who have been in AFib for a really long time, where it doesn't really bother them from a lifestyle standpoint, might be reasonable to just leave an AFib. So we don't always have to treat AFib and try to get a patient back to normal rhythm. It really depends on the patient. And so really the patients whom we treat most of the time are patients that exhibit significant symptoms from their AFib, and where we can see a clear-cut benefit to getting back to normal rhythm, where the patient can appreciate, gosh, I feel a lot better in normal rhythm. And one of the ways that we help figure that out, a lot of times if somebody shows up in AFib and they're not quite sure if they're having symptoms from it or not, they're not quite sure when they went into AFib, that's a lot of times where I'll use the cardioversion. As I said earlier, that's the electric shock that gets somebody back to normal rhythm. We use that, and we know that's a temporary fix, but what we're hoping to do is get somebody back to normal rhythm, and then hopefully they stay that way for at least a little bit of time so that they can sort of feel it out, test drive what normal rhythm feels like. And if they feel a whole lot better and they say, gosh, I didn't realize how poorly I felt when I was in AFib, then we sort of take a more aggressive stance on trying to keep them in normal rhythm.
Okay, wonderful. Thank you. And as we bridge over to ablation, this is an interesting question. Under what circumstances is electrical cardioversion a good choice? And why would ablation be the first choice before trying electrical cardioversion?
Well, so as I said, the cardioversion procedure is sort of like hitting reset on the heart. And more often than not, we can get somebody back to normal rhythm who's been in AFib with a cardioversion. In fact, I'd say that close to I don't know, 90+% of the time, you can get somebody back to normal rhythm. Now, the question is, how long will they stay that way? And we know that this is a temporary solution. All of the triggers and all of the risk factors that put somebody into AFib in the first place are still there. We're not really getting rid of any of those. We're not even treating the heart muscle with necessarily with medication that tries to keep that heart in normal rhythm. And so a cardioversion is often just a way to kind of see how somebody feels. Now, having said that, sometimes we use cardioversion in combination with a medication. So we put somebody on antiarrhythmic medication along with cardioversion, and we hope that once we convert the patient back to normal rhythm, that the medication will help maintain normal rhythm. And that's a good strategy as well for a lot of patients.
Right. So, moving into ablation, first question is, are people always put to sleep for an ablation, or is it done awake? And is there an awareness of, pain if you're awake?
The way I do AFib ablation, I always have people under general anesthesia. I don't do them with conscious sedation, which is typically, I mean, when somebody says they're awake for a procedure, generally speaking, they're getting some medication through an IV. Now, AFib ablation can be done under conscious sedation, and in many places is done under conscious sedation. And there is, in that scenario, there is some awareness of what's going on, but typically you're sedated enough that you're quite comfortable. It just depends on the strategy of what the procedure is going to entail and how it's done in that specific hospital or with that doctor.
Okay.
So, but generally speaking, it's not a painful procedure. It's as I said earlier, it's minimally invasive in that we start some pretty big IVs. But apart from that, there's not too much in the way of feeling on the inside of the heart when we're working. And so it's generally speaking not a procedure that even though you're asleep, that your body's experiencing pain from the procedure.
Okay, thank you. Can Flutter be taken care of during an AFib ablation?
Yes, and it often is. Especially if somebody had let's back up a step, because Melanie, you mentioned Flutter. Atrial flutter is a cousin of atrial fibrillation. Those two rhythm conditions go together, and they exist in the same patients a lot, or even the majority of the time. Patients tend to drift in and out of atrial fibrillation, and then maybe down back into an atrial flutter, and then back into AFib, and so a lot of times atrial flutter circuits are interrupted during the ablation procedure as well, and that usually adds a little bit of time to the procedure, but not a lot.
Okay. So another question is around, and actually there's several questions here, and so I'm going to try to package it up into a single question. These people are asking, what are some of the things that can cause an ablation to be harder to do, such as an enlarged left atrium? Are there some other conditions? If I have an enlarged left atrium, is another ablation appropriate? And when is it appropriate to have another ablation? So a bunch of different questions we'll address in one.
Right. So I think we'll kind of break this down into what are some characteristics that might make an ablation procedure less likely to be successful, maybe is a way to look at it, because I think what they're getting at with the enlarged left atrium, when somebody's been in AFib for a long time, that's just the rhythm condition in and of itself can cause dilation, or does cause dilation or enlargement of the left atrium. And so while it's sort of a marker of somebody who's been in AFib, it's also, as that atrium expands and gets bigger and bigger and bigger, it sort of wants to be in normal rhythm less and less and less over time. And so the procedure tends to be less likely to be successful in somebody with a markedly expanded left atrium. There are, of course, other conditions. And so what goes along with that dilation? So scar tissue tends to set into the left atrium. It can create, the AFib ends up, as it has been more persistent or the heart's been in AFib over time, the disease goes from being one of, remember I showed you that slide where we said it was in 1998, they figured out that AFib starts in the pulmonary veins in most, if not all patients. It goes from being a disease of triggers, of electrical storms happening in the pulmonary veins and then causing the atrium to fibrillate. It goes from that type of disease to more of one where the whole atrium's just sick and it can't help but to just fibrillate. And so we call that a disease of the muscle itself more than a triggered phenomenon. And so various things, and then other things can cause the procedure to be less likely to be successful. Somebody who has untreated blood pressure, or somebody who has untreated sleep apnea, snoring at night is a very potent trigger for AFib. And so if you don't manage some of these other conditions, if somebody drinks excess alcohol, or if somebody's markedly obese, if you don't try to mitigate some of those other risk factors along with trying to treat the rhythm, you're really going to be significantly less likely to have a successful outcome. And so we treat the whole patient, right? We manage risks from various different angles, and then we get to the procedure that we can do to help reduce the incidence of AFib. But we've got to attack it from a lot of different directions. It's never going to be as likely to be successful unless you manage all those other risks as well.
Okay. So can you ever go off of anticoagulant after you've had an ablation?
Yes, some patients do. Now, patients that are at very low risk before their ablation, low risk for stroke, we do a minimum of 2 months of blood thinner post-ablation is typically kind of our standard practice. And so those very low risk patients could potentially come off their blood thinner after their ablation procedure. We use a risk scoring system. We look at various different patient characteristics, things like high blood pressure, diabetes, heart failure, and so on, to predict a overall stroke risk, and age is another one of those. And so the patients that are not truly very low risk, but kind of in a middle range, sometimes some physicians utilize the data that they get from the long-term monitors to help guide the decision regarding blood thinner. But the guidelines, the atrial fibrillation treatment guidelines from the professional societies state that the standard approach for patients should be to keep treating with blood thinner based on risk, even if they've already had an ablation procedure. But it varies. Some patients have a compelling reason to want to be off of blood thinner, and looking at that rationale very closely, we can individualize treatments based on the data that we have.
Okay, awesome. So moving into the monitoring space, which is the best watch, consumer wearable, to signal AFib?
Gosh, that's
a tough one.
That's a tough one. I can just tell you that in my experience, the Apple Watch has done a remarkable job of detecting and cataloging atrial fibrillation for so many patients. I believe Apple, in terms of atrial fibrillation detection and recording, ECG recording, has been their algorithm has been out the longest. It was the first to get the FDA approval for that, for the AFib detection. It's been studied in the Apple Watch study for cardiac rhythm management. So I think that the Apple Watch has data supporting the use of that device. A lot of my patients have Apple Watches, and they utilize that data. But I would say that in terms of a rigorous analysis or rigorous recording of rhythm, sort of the 24/7 recording, the full disclosure of the rhythm, really the best way to do that is with an insertable monitor. Really the only way to do that over the long term is with an insertable monitor.
Great. So with an already implanted Medtronic pacemaker, can the cardiologist identify my AFib episodes?
Yes. If there is a wire up in the upper chamber of the heart. So some patients only have a single chamber pacemaker with a wire down in the bottom chambers, or one of those leadless pacemakers. Now Medtronic developed the world's smallest pacemaker also, and that's just a single unit that sits down in the bottom chamber of the heart, and it doesn't necessarily see what's happening in the upper chambers. There are different versions of that device, but the most basic version doesn't. But a dual chamber pacemaker, somebody that has a wire up in their right upper chamber, we should be able to pick up AFib events on that pacemaker.
Okay, great. So how is the insertable cardiac monitor applied? And do you have to, is it covered by most insurance? And, and what do I need to know if I'm interested in one? It's a bunch of different questions in one, but
yeah, so just kind of like an introduction to that and insurance coverage and so on. Yes, most insurance does cover it. Sometimes you've got to have, do something prior to getting the monitor, like wear an external monitor for a period of time. That's just kind of jumping through some of the hoops of insurance. They want to make sure that we've done kind of the basic analysis first before we move on to an invasive type of thing, which makes sense. Medicare does cover the insertable monitor as well. And depending on the use case, some of these things depend on why we're putting it in. And so some of the insurance things sort of depend on the reason why we're using the monitor. But getting into what to expect, it's done on an outpatient basis. Sometimes it's done in a doctor's office. Sometimes it's done over in the hospital. But it's generally speaking a very quick procedure. It's typically done with just local anesthetic. So we numb up the skin, we make a tiny little incision, and the monitor injects under the skin. It'll go on the chest, sometimes adjacent to the breastbone. For some patients, it'll be in a different position, just depending on the patient's anatomy and what would be comfortable for them. And as I said, it's basically an injection of that little monitor under the skin. Sometimes the closure will be with a stitch or a staple, but often it's just with a Band-Aid. And patients go home a few minutes later, and there's really not a lot in the way of activity restriction or anything like that after getting a monitor implanted. A lot of times we just want somebody to kind of take it easy while they wait for that wound to heal up, but typically they can get back to their usual stuff within a day or two.
right. Another question is, if I've done well with the monitor at end of life, can I have it replaced?
You can, and a lot of times patients do, because remember, AFib is a long-term kind of disease. We want to keep an eye on it over an extended period of time. Now, some patients, having that data doesn't really make a big difference to their treatment or management at that stage. That is to say, for example, somebody who's going to be on blood thinner anyway, somebody who doesn't have any more symptoms of their AFib, and somebody who's quite content with just checking their pulse or doing spot checks for the future, they may not have their monitor replaced. You can either get it taken out, and some patients just opt to leave it in. If it doesn't bother them, they just opt to leave it in and not mess with it. Other patients where we're still making changes to their medications or considering another ablation, or we've seen some potential risks for going back into AFib, some of those patients will want to swap out their monitor with a new one so that we can continue to monitor for the next several years the rhythm. So it depends on the patient.
Okay, great. One final question as we try to wrap up. What is the recurrence risk of AFib after an ablation over time? 1 year, 2 years, 5 years? And is that different with a second ablation?
That's it's sort of a complex question, and it really, again, like many of these things, AFib is such a patient-specific disease in terms of outcomes of different treatments and what have you. Kind of the easy answer is that somebody who has an ablation for paroxysmal atrial fibrillation, or the type that is kind of early stage that comes and goes on its own, it's around an 80 to 85% chance of being AFib free at a couple of years post-procedure. That, if you look at that patient group over time, you tend to see that with time, as the patient gets older, as their risk factors mount, and so on, that there is, there's a drop off in terms of the responders to the treatment. And so, the easy answer, and kind of one that's thrown around, is around 10% per year kind of fall off of that AFib-free survival curve. But for other types of patients who have more advanced AFib when they have their ablation procedure, they could only expect around 60 to 65% chance or less of being in normal rhythm over the long term from their procedure. So it's a bit of a tough question to ask or answer, and it really is nuanced with a lot of things. Like, some patients have to have a procedure, but they have to take medication in addition to the procedure to help keep them in normal rhythm. And then, but the second part of that question was, could you have a second procedure? And the answer is, for many patients, the answer is yes. You can have a second or even third or fourth procedure. You may be getting into diminishing returns with more and more procedures, but does the outcome improve? Yeah, I mean, if we go back in for a redo ablation and we find some of those targets that may have, the tissue may have come back, grown back, or reconnected, as we call it, and if we hit that one more time with the ablation procedure, we might have a really nice outcome in that patient where they didn't respond at first. And why do we sometimes see that? Well, when we do the initial procedure and say we freeze the tissue or burn the tissue, you can get kind of a stunning effect that makes it to where a patient looks like they have their electrical activity all fixed up, but as the tissue heals, there may be gaps in the lesion, and so on. So sometimes going back in helps touch up those areas, and you can get a really nice result.
Great. Thank you so much, Dr. Colombowala. And there's one more question that keeps coming up over and over again in the questions, and that is, how can I watch this again, or how can I share this with my family? And for those of you that are here, you will receive an email to let you know when the replays are available so that you can watch it again and you can share it with family. So I'd like to thank you all for joining us today, and a special thank you again to Dr. Colombowala for an excellent presentation and for sharing his experience and expertise in managing atrial fibrillation. And I hope you all have a great day, and thank you again.
Thank you.